Thank you for joining us. So Monica's actually, she's just driving home from work. Of course, she was at work late, like all of us always are. So she'll be joining us in a couple. She's here, but she'll just be joining us in a couple minutes. So I'm going to introduce us, and then we'll kind of go through some slides. So I'm Shannon. I'm a nurse practitioner. I work at Columbia. I specialize in interstitial lung disease. And Monica, I don't know if I can introduce you or if you want to hop in.
Yeah. Yep. I'm Monica. I'm a nurse practitioner in rheumatology, and I currently practice in Northwell. I work in 3 different offices because I'm a little bit crazy. But I'm in Queens, I'm in Long Island, and Manhattan as well.
Okay.
So if you don't mind, Allie, just going to the next slide. Thank you. So we're doing this talk basically to try to bridge these specialties. We try our best to make sure that Pulm discusses with Rheum, discusses with primary care, and then of course with home care. So we're going to go through 2 cases when we talk. But again, if at any point you'd rather kind of steer this in a different direction, please let us know. We're happy to, especially since it's more one-on-one. Next slide, please. Oh, sorry. Our founding sponsors for this are BI, which is a drug company, as well as United Therapeutics. So we're going to be discussing a case-based journey through ILD in rheumatologic disease. So our first case is about, I thought RA was just about joints. Next slide, please. So this patient is a 67-year-old male who presented to the clinic with increasing fatigue, shortness of breath, and mild exertion over 6 months. Past medical history was a seropositive RA 4 years ago with a rheumatoid factor greater than 300 and an anti-CCP greater than 60. At that time, he was started on methotrexate and he had add-on treatment of adalimumab. Sorry, Monica, that's definitely yours to say. Added 2 years ago, given his ongoing disease activity. So for Anna and Anne, thank you for joining us. In thinking about this patient, so obviously he was seen by a rheumatologist. If this were to be your patient, what symptoms that we just said would make you be a little bit concerned for him to potentially have ILD or interstitial lung disease?
The fatigue and the shortness of breath.
Yeah, definitely. Perfect. Thank you. And of course, we know with RA, he's on some immunosuppressant medications. Of course, those can make you feel fatigued, but definitely the shortness of breath specifically could be very telling for a lung condition as well. So then you did an exam. So this is, you in primary care, and you heard inspiratory crackles on auscultation. He had a normal oxygen saturation, but when he was walking, he desaturated. So for us, that would mean that his saturation was less than 88% on exertion. His x-ray showed interstitial markings, and you, as an astute practitioner, sent him for breathing tests, PFTs, that showed a forced vital capacity, FVC, of 65% and diffusion capacity of 41%. You then sent him for a CT scan, high-res HRCT, that showed basal predominant reticulations with honeycombing consistent with a UIP pattern. These, I'm not sure how familiar you are with these specific things, specifically when we say UIP, but just something to keep in mind that someone who has a UIP pattern means that it is indeed basilar predominant, meaning in the lower lobes, and is also the most prone to progressing. So a UIP pattern is what we tend to act the most quickly on, and want to be very, cautious about the risk of progression in those cases. So it asks now, based on guidelines, what would be recommended for this patient. And if you remember back at the previous slide, we had said that this patient was on methotrexate and immunologic. And so based on these findings, I'm curious if you all have any thoughts about maybe what would be on your mind if maybe you'd want to refer this patient somewhere, or maybe you'd want to make some changes to the medications. Do you have any thoughts on that? I know it's
I would
kind of
refer.
refer to who?
Either a pulmonologist or
I think you hit the nail on the head. To refer to pulmonology would be really the best next step. Next slide, please. So you referred to pulmonology, like you said, good job. And basically at that time, what we would do in the pulmonary practice is to work to understand why this patient has this underlying interstitial lung disease. And of course, it sounds quite logical that this person, we know they have rheumatoid arthritis, and then we know that they have this lung disease, but not in every case could those 2 things be affecting one another. It's not that everyone with rheumatoid arthritis gets this lung disease, nor is it that if you have lung disease, it has to be caused by rheumatoid arthritis, if that makes sense. However, based on what we know of this patient, this UIP phenotype, again, with the most progressive radiologic finding that we see is often tied to patients who have RA, and especially people who are men, former smokers, and rheumatoid arthritis. They unfortunately do tend to have ILD much more frequently. And so with this, the question becomes, what do we do next here, right? This patient has been on some treatment. He was on methotrexate and then also the biologic 2 years ago. He has this high titer of the rheumatoid factor. He's older and male. Like I said, those two high risks and a positive anti-CCP, meaning that he's a high risk profile for continued progression from a pulmonary perspective. So in this case, the questions that are kind of coming to us now are, what baseline and follow-up assessments would you establish for this patient? And should the methotrexate be continued? And I know you said that you work in home care, primary
Okay.
care. And so, I guess if you could put yourself in maybe my shoes, or if you were to specialize in pulm, what do you think our next best steps would be? You had already done PFTs, you had done a CT scan. What do you think we need to do as we continue on with this patient? I can give you the answer too. I know I'm picking on you.
Maybe stop the step. He's on the it talks a lot of times 4 years, so maybe would I stop one of those? I'm not sure.
That's
I'm just
that's a perfect guess. I know I'm picking on you. I'm so glad you're here. Be talking to myself. So, with that, yes. So there's this in pulmonary, there's this thought that methotrexate can indeed cause um, toxicity to the lungs. It's pneumotoxic in some cases, not in every case. And so a lot of pulmonologists, when they see patients, they don't want them on methotrexate at all because there's a risk that it can cause their lung disease to progress. In other cases, people on methotrexate get lung disease because of the methotrexate alone, although that is much more rare. And so should the methotrexate be continued is a good question. I think it would depend on which specialist you spoke with. If it was me and this patient was very well controlled from a rheumatologic standpoint, meaning that their joints weren't bothering them, we didn't see a lot of swelling, they didn't have terrible morning stiffness, their labs and titers were relatively stable. I don't know how forceful I would be in stopping the methotrexate. However, in many cases, that's not the case, right? If a patient is having lung disease, but we're also seeing flare of their rheumatologic condition, it's always wise to get them off methotrexate and then put them on something a little bit more helpful to the lungs and the joints as well.
So, Shannon, just to add to,
Yeah,
most pulmonologists will make me immediately stop the methotrexate. And from my own practice, I think I will feel safer to stop it as well. But we know that it's not as bad as, people think it is.
exactly. I think that's why I said it depends who you talk to, because it's I think there's risk and benefit to each, right? So if Monica, if you agree, like if this patient didn't have their rheumatologic symptoms controlled on methotrexate, I think definitely you and I both would say let's put them on something maybe a little bit stronger. Yeah,
Oh, for sure. Yeah. Yeah, definitely requires a little bit of change in there, particularly because of the lung disease.
absolutely. Next slide, please. Great, thank you. So now we know that this patient was previously on methotrexate, and what we decided to do was initiate a couple of different treatments here, right? So in the pulmonary practice, so the first thing that we started was something called nintedanib, which is another name for that is OFEB, and this is an antifibrotic treatment. And the reason we would do that again is I keep coming back to this UIP pattern, but this patient had a very high risk of progressing, right? They had the UIP pattern. They were a man. They were, I hate to say of older age, 67 is actually quite young, I feel like nowadays, but to the medical standpoint, he's a little bit older. And I'm not sure if they did mention if he was a smoker or not, but if indeed he was, even in his
I
past.
think at the beginning they said he was a smoker, if I'm not
No, they
mistaken.
did.
Yeah.
Good. Thank you. So definitely starting him on an antifibrotic therapy is wise. The thing about these treatments is that when we start on an antifibrotic, that will only help the lungs. There's no joint effect of these antifibrotics, meaning it's very lung specific. So of course, we'd also have to think about putting them on something different for their rheumatologic, their joints as well. And so this patient, we stopped methotrexate and we switched them to abatacept. And Monica, there's a question here with what biologics might also be preferred. I'm curious if you have any thoughts,
I
if this
mean,
was the case.
with the lung disease, we would prefer rituximab. That's
Hmm.
that's usually our
Hmm.
go-to when there's
Hmm.
any sort of lung disease. So abatacept, I think I worked with a few pulmonologists that were okay as well with the ILD. But definitely rituximab will be an option
Hmm.
here.
Hmm. Yeah, or even like tocilizumab I have in my head.
Yes.
I think so. Anyway, all of this to say that, like all things, it's a science and an art. So I think a lot of things are depending on who you work with and who's comfortable doing what. And then basically, from a pulmonary perspective, anyone with ILD or lung disease in general, I'm sure Anna, you see this a lot. We love the vaccine, so we'd be very hopeful that they would be willing to take the pneumococcal, the flu vaccine, COVID-19, and of course RSV as well, specifically with known lung disease, just to prevent any risk of progression. Um, and then moving forward on this patient, what we would likely do is continue ongoing monitoring with breathing tests every 3 to 6 months and a high res CT scan about every 12 months or so. Um, any questions or thoughts on this case before we keep going? And to everyone who has joined us so far, thank you for joining, and please feel free to jump in and interact as much as you feel comfortable. Any questions before we keep going? Great. Okay, next slide, please. Or sorry. So summary and teaching points here. So basically, we knew that this patient was a high risk rheumatoid arthritis patient who needed proactive ILD screening. Unfortunately, in this patient's case, he had already been having symptoms before he was even seen or did breathing tests. And I think often rheumatologists, Monica included, when they have a patient who has rheumatoid arthritis or scleroderma, they tend to do these tests a little bit more proactively. Because, of course, once we see symptoms, that also means that we've had some loss or some decline in their breathing tests, or, of course, seeing some reticulations or changes on the CT scan. And the sooner we can catch these patients, the sooner we can hopefully tailor treatment to help them to slow down the progression of the scarring in the lungs. Um, High-res CT scan and diffusion play critical roles in early identification. And I'm not sure if everyone's familiar with breathing tests, but when we talk about the diffusion capacity, it's basically a test that will tell us how well oxygen can get into the bloodstream. So kind of through the alveoli, the air sacs of the lungs into the bloodstream. So of course, if there's inflammation or swelling in those areas, it's much more difficult for that diffusion or for that air to move into the bloodstream itself, causing shortness of breath and oxygen needs. So if there is someone who has a low diffusion in our minds, we always say to ourselves, okay, will this person need oxygen? How are they doing when they're exercising? Are they able to exercise? Are they able to leave their house, etc.? Um, like I mentioned, UIP patterns carries a poorer prognosis when we see that on CT scan. And so starting those antifibrotics, the anti-scarring medications early can be quite helpful, of course, in slowing decline. With the caveat, like I mentioned, that antifibrotics, anti-scarring medications do not have any effect on the joints. And so therefore it's often used as add-on therapy or dual therapy with something more tailored from a rheumatologic standpoint. And lastly, cross specialty care with shared decision making is essential, as Monica and I already kind of mirrored here, that depending on who you talk to about specific cases, there's always different people who do different things. And in some cases, we have a very clear cut path that we can take in terms of treatment. But in others, we have a lot of different options that we want to work through pending risks and benefits and side effect profiles that unfortunately most of these medications carry. Any questions on this RA patient, rheumatoid arthritis, patterns, thoughts before we move on to a different case?
On my part,
Great, thank you. All right, great. So here we have case number 2. It's getting harder to breathe, which is talking about progressive ILD or interstitial lung disease in systemic sclerosis. Next slide, please. So this is a kind of a typical case, unfortunately, that we'll see. So this is a 56-year-old Caucasian woman who comes in with worsening dyspnea over 6 months and dry cough. She has a known diagnosis of diffuse cutaneous systemic sclerosis for 2 years. Next slide, please. Clinical features for her are skin thickening proximal to the elbows, Raynaud's, and GERD or reflux. And her antibody profile shows a positive SCL70. So in this case, of course, we're lecturing about ILD itself, and we know this patient has an underlying scleroderma disease. But similar to the last case, which type of baseline screening would you want to pursue at this point if you were seeing this patient maybe in a primary care practice? So to the last case, we talked about doing
They had
breathing
a
tests.
CT scan.
Exactly. Thank you so much. The high-res CT scan, the breathing tests, and of course, I don't know if it'll go through this in the next slide, but anyone with scleroderma, we also always want to be a little bit more mindful about the risk of pulmonary hypertension. And so having shortness of breath and being fatigued with this disease or many rheumatologic conditions, echocardiograms as well are never a bad idea. But of course, as we're thinking about the lungs specifically, exactly to your point, Anna, thank you, we would want to do breathing tests and a CT scan. And then the question is, what is her risk of developing ILD? And unfortunately, we know with scleroderma diagnoses that anywhere between 40 to 60% of people with scleroderma do get ILD. The severity of that varies quite largely the same way as the severity of scleroderma as a whole. But with that in mind, her risk of developing ILD is quite high, which is why we decided to do some testing. Next slide, please. So ILD onset, she had worsening dyspnea over 6 months. She was desaturating on exertion. Again, similar to the last case, where the saturation less than 88 is when we would want to go ahead and start them on supplemental oxygen. Her breathing test showed that she had an FVC, a forced vital capacity. The amount of air in her lungs was 71% predicted, and her diffusion capacity was 52% predicted. In general, this isn't exactly scientific, but a diffusion capacity of 50%, 50 or less, often makes us in the pulmonary world believe that this person would need oxygen on exertion. So if you can put that in your mind, someone with that diffusion of 52%, it already means that their lungs are already quite sick. And these numbers are downtrending. And the high-res CT scan shows early honeycombing, which is exactly what it sounds like. We'd see these stacked cysts on top of each other, which is actually the end stage of scarring. Scarring kind of goes through a process when we look at CT scans. So seeing early honeycombing means that this person is already progressing in their lung disease, and it's again a UIP pattern, which, if you remember, is the most prone to progress. And so the question is now, what do we do with this patient? What would be next steps in management? And would we want to initiate treatment, refer to transplant, discuss more things? Does anyone have any thoughts on those? Okay, well, we're going to go to the next slide and we'll discuss kind of what the next best options might be here. Monica, do you want to take this one?
That's
Yeah,
fine.
great.
Yeah.
Thank you.
So usually, we work hand in hand with the pulmonologist in cases like this, in most cases, really, because we need their input, particularly the PFTs is super important. And mycophenolate is very often used for us. It's kind of like a very common drug. So in this particular case, mycophenolate was initiated, and the dose starts at 500 and goes all the way through 3 grams. So it's about 6 tablets a day, but there is a liquid form that I usually prefer because it's just like a tablespoon versus 6 tablets. So in this case, we definitely started mycophenolate, and then, with discussing with pulmonology, he was referred to the transplant for consideration. As Shannon said, when you see honeycombing, it's really like, that's it. You cannot reverse the process anymore. Whatever scarring is there is going to stay no matter what medication it is. So in this particular case, the medication is just to hold and progression of the disease, but it would not turn around the clock anymore. Again, vaccines super important in these patients. They tend to get pneumonia very, very, very easily, and that puts sepsis. So vaccine is mandatory in all of those patients. Want to talk about non-pharmacological interventions, Shannon?
Yeah, sure. So, in terms of this, in this same patient, we always want to talk a little bit about what things we can do other than just simply throwing medications at them, right? So, when we think of someone who's short of breath, we like to think specifically about, of course, oxygen therapy, pulmonary rehab, um, physical therapy, etc. Does anyone have any other thoughts on things that maybe this patient would benefit from, whether it could be the things I mentioned, occupational therapy, anything else you think we missed? Okay. I just want to give a little bit of I'm not sure if everyone's familiar with pulmonary rehab, but we do tend to use this quite frequently, especially in patients who maybe are having more difficulty exercising on their own, whether that's because of motivation, depression, or oxygen needs. And so going to pulmonary rehab ultimately is just that. They'll get, the therapist will get the patients onto the treadmill, monitor their oxygen, titrate oxygen as needed, and build strength. And we know that increasing strength of the legs, specifically the quads, has a very direct result with longevity in patients with lung disease. And so we really want to make sure that these patients are staying as strong as they can from a muscle perspective as well. Um, and then, of course, the next question would be, what would we do for next steps in terms of treatment? We put this person on mycophenolate, which is a medication that's, an immunomodulator. What else would we want to be aware of here or look out for someone with scleroderma, knowing that she already has this disease that can be progressive? Does anyone have any thoughts that maybe we didn't discuss on this case that probably would come up in the next visit or so? No, that's okay. The one thing I think that might be missing is that in this case, we started this patient on mycophenolate, which is great to help treat the scleroderma and also the inflammatory component of the lung disease. But again, that scarring that's already there, like Monica mentioned, once there's scar, we can't reverse it. So we'd also probably want to make sure that we're focusing on preventing additional scar by really thinking about also antifibrotic therapy in the future. Next slide, please. Thank you. So, summary and teaching points here. Recognizing high risk ILD patients and diffuse systemic sclerosis can be really helpful, especially because a lot of these patients are quite young. And so, being mindful, like I mentioned, of anyone who has scleroderma, to just think if they are to come in and say, I'm having this cough and it's not going away. Think as primary care uh, providers, we tend to think, okay, you have a dry cough. Do you have allergies? Do you have reflux? But when someone has scleroderma, this underlying disease that's so prone to lung disease, it's always smart to have in the back of your mind, could this be something more serious? So as you work your way through that kind of pathway, we just want to make sure that you're having that in the back of your mind. Of course, the importance of early recognition of progressive fibrosing ILD, initiating immunomodulator therapy, which would be the mycophenolate, and the timing of antifibrotic therapy, and of course, the timing of referral to transplant and use of antifibrotics. The one thing we didn't talk too much about, of course, is the use of palliative care in patients who have a known progressing disease, which is always a really helpful next step or something to discuss what things could look like as, unfortunately, as things may progress rapidly or even slowly.
Yeah, particularly in the case of systemic sclerosis, where we don't have a lot of therapies. So, talking about palliative care is always important. There's a time and place for everything, but I think that, as the disease progresses, and unfortunately, there is no medication that completely controls or stops the progression of this disease, it's always good to have in the back of the mind talking about palliative care.
Absolutely. Okay. Next slide, please. So we'd love to, hear from you if you all feel comfortable. So based on these cases that we discussed, anything that you learned or something that you'd like for us to kind of discuss more openly, or any questions about the things we mentioned, we'd be happy to go through. What are your key takeaways? Has this changed the way that maybe you think about management of these specific patients? And is there any part of this diagnostic or treatment timeline you feel very confident in or least confident in that Monica can help to Monica or I can help to shed some light on. Any thoughts about these?
I think my takeaway is very important to have multidisciplinary team effort to help the patient. And just as you said, work closely with the pulmonologist and the patient education as to what to expect each step of the way. Because I guess it could be
Really,
something scary. So mainly like patient education.
that's a great point. And I'm sure you all get this a lot when you're dealing with patients, but the first thing people will do when they leave our offices, whether it's pulmonary or rheumatology, or I'm sure in primary care, the first thing they do is Google. And education is definitely the most important thing we can do to hopefully help people to stay calm with these very scary diagnoses, especially as it can be quite progressive, but not always, and making sure that people feel comfortable in their care. It's a really great point. That patients feel comfortable in their care, and also we as providers feel comfortable ordering and monitoring treatments as a team.
Yeah, absolutely. You cannot do this by yourself. My diseases are highly complicated, and the rheumatologist can never be alone. So relying on my colleagues, pulmonology, cardiology, nephrology, the patients in the end have a large phone book with every specialist. But that's because you want the best case scenario, you want to stop progression, and you don't want any complications. So um, really seeing them as a prevention, just to get things rolling or pick it up before things get really bad is always the best case scenario. When you're starting to get, particularly with scleroderma, getting to diagnose the lung disease earlier is better. It has a much better prognosis than if you get it at the end when you don't have much to do but deal with the fibrosis and then maybe lung transplant.
Anyone else have any thoughts or questions regarding what we discussed, or anything they want to discuss further?
They're very shy.
It's okay. It's okay. Well, this is, that's all we have. So we are here to be a resource at any time, whether it's, in the next couple of minutes or, as time goes on. It's these patients can be kind of daunting in a way because the diseases can be progressive and it is quite scary. And so definitely, for us to feel confident in the care we provide, and also to take care of ourselves at the same time, because sometimes these patients, it can weigh on you as well, like many different diseases, or maybe being a healthcare worker in general. So if anyone has anything else they'd like to add, we'd be happy to hear it. But otherwise, thank you all so much for joining us. It's been great to go through these things. And if you ever need anything, Monica and myself are happy to be a resource at any time.